call upon Dr. Kavita Kalevani to give her talk on clinical guidance and support how best to achieve. She is a senior consultant from Shakti Netralaya, and I really owe a lot of thanks to her for giving so much of energy and help for all my pediatric and neuro webinars. Thank you so much.
Thank you so much, ma'am, for the kind invite and the words. So this is a first type of talk for me, different from routine pediatric ophthalmology clinical topics. So I prepared what I could do justice to the topic. So I'm going to tell a rough guidance to how a pediatric ophthalmology and neuro-ophthalmology fellowship from a fellow point of view and from a trainer point of view. So why does someone need a fellowship after being fully qualified as an ophthalmologist? So to narrow down your interest and focus on your interest, to specialize more, to acquire unique clinical and surgical skills and expertise, to get in-depth knowledge in particular area of your interest, and as a job requirement. Nowadays, many of the institutes and everywhere, they require a fellowship for you to work in their institutes. And what, as a fellow, do we look for in a fellowship? Everyone wants, the duration is very crucial. So you don't want a too long a fellowship because it's usually after your post-graduation. So you want a crisp fellowship, not long, not too short. And specialized and qualified trainers and teachers you would expect to give you training. And highly equipped training center and hospital is of course essential. Availability of state-of-the-art technology, available allied departments within your place so that you don't need to go outside for extra experience, and good patient turnover, always important, and independent clinics and surgical opportunities are always essential to a good fellowship. So for pediatric ophthalmology fellowship, we do not need elaborate instrumentations, virtual reality, and all those things that the previous specialty people said they require. All we need is very simple gadgets. So the prerequisites for a fellow is qualification, of course, and a basic general ophthalmology knowledge and skills. You shouldn't come to a fellowship expecting to gain general ophthalmology knowledge. It's expected if you're already an expert in managing basic clinical skills in ophthalmology. You have to have compassion towards children, which is really important, and really a fruitful thing if you have patience to deal with children. Sorry, oops. So retinoscopy skills is very, very important because many times children, it's difficult to do a refraction and you can't rely on someone to do this for you. So you need to have a good retinoscopy skills. Fundus examination skills is very important. Adult cataract surgery skills are very useful if you are planning to do a fellowship where pediatric cataract surgeries is also part of your training. So the duration ideally is around 1 to 1.5 years with a specialty posting of 9 months. Neuro-ophthalmology, these are allied specialties which a standard pediatric ophthalmology fellowship like ours offers. We have a neuro-ophthalmology training for 1 month, retina training for 1 month, oculoplasty training for 1 month, and then you get an independent 3 months experience in managing OPD. Allied clinics like orthoptics, contact lens department, and low vision clinics, all these exposure go hand in hand with pediatric ophthalmology fellowship. So what are the goals of the fellowship? To provide extensive academic and clinical stimulation and activities throughout the fellowship, to utilize library services with access to all relevant journals, to have a comprehensive training in clinical evaluation of most common pediatric disorders, preoperative evaluations, and postoperative assessments, to gain experience in pediatric ophthalmology related outpatient procedures, to actively participate in regular journal clubs and classes and to make presentations, to be able to attend conferences and even publish papers through your own research work, maintaining OPD and surgical logbooks, which is crucial to fellowship. So stepwise we do this. There is a basic level where the first 6 months you acquire basic cognitive skills, basic theory, anatomy and physiology knowledge, retinoscopy training, and basic clinical skills like vision testing in children, sensory motor evaluation, etc. There is a parallel exposure to surgical expertise along as like assisting simple procedures performing simple steps in strabismus surgeries, and exposure to fields like retina, oculoplasty, and neuro-ophthalmology clinics are also parallel. The second level is a standard level where more advanced clinical skills are being exposed and patient assessments individually or done, which is verified and cross-checked by a senior. Allied specialty exposure, here orthoptic training and low vision clinic exposure is given. And surgically, similarly, you have supervised but simple surgeries you are expected to perform by yourself. And you have specialized clinical skills like test charting, diplopia charting, all that exposure that you do yourself starts. And then advanced and very advanced levels are the final level of the last 6 months of your fellowship, where you get advanced skill acquisition, assessing special children, independent workups, and then pre-op assessments and decision making is in this step. And then you get a teaching experience to teach PGs in your institute, classes, specialist classes. And surgically, you have a parallel independent simple surgery exposure and supervised complex surgeries are given at this point. So these are the things. And strabismus knowledge and diagnostic skill goals. So these are various goals that we expect and we provide for the trainees during the fellowship to apply knowledge by movement anatomy, neuroanatomy, to describe clinical applications like sensory adaptation in strabismus patients. These are crucially made points. It's taken out from a lot of curriculums, and this curriculum has been formed to be able to treat and recognize all types of esotropias, all types of exotropias, to be able to recognize complex strabismus patterns, restriction, paralysis, and dissociative strabismus, complex alphabet patterns and muscle dysfunction, able to diagnose, and able to read orbital images, which is relevant to our specialty, and other techniques like test charting and diplopia charting, and medical and surgical management of strabismus patient comes at this point. And to be able to diagnose and correctly manage those strabismus patients in whom refractive management is indicated, and to competently be able to perform retinoscopies in children. So, similarly, pediatric cataract training, we have a stepwise clinical and surgical exposure to pediatric ophthalmology, especially cataract, where adult cataract training, even if you have had an exposure, is usually given in the first 6 months to give you a heads up to the pediatric cataract surgery. Glaucoma assessment, where IOP checking, etc., is being covered in this, and examinations under anesthesia you are able to do independently, and simple procedures like suture removals, all those things are managed or addressed. Trauma management in emergency management of trauma, again it's covered in this, and supervised and independent simple pediatric cataract surgeries are addressed here. So, pediatric ophthalmology goals: to perform and interpret eye examinations in children, perform refraction, identify and manage amblyopia, participate in the diagnosis and management of allied retinal conditions, which is unique to pediatric ophthalmology, and recognize and refer pediatric uveitis in children. We do not cover the treatment part of uveitis in pediatric ophthalmology fellowships. To be able to recognize and treat simple optic neuropathies in children, recognize and treat nystagmus in children, and ocular and non-ocular manifestations of systemic diseases to be able to identify and refer. So, continuously, fellowships are successful when you are able to monitor and assess periodically. Each month, consultant feedback is taken. Each level theory and clinical assessments, like once in 6 months, is conducted. And auditing of files of independent OPD is routinely carried out to enable teaching. And logbook review is a very important part of our fellowship program. So, logbooks are maintained, month-wise evaluations are done, supervised basic workups, at least 10 should be entered in the logbook, at least 30 cyclopedic refractions should be done, pediatric journal club presentation should be there, postgraduate and optometry classes attended and taken should be entered in the logbook, theatre-assisted surgeries and performed surgeries and points taken from those assisting surgeries should also be maintained in the logbook. Adult cataract surgeries also separately should be maintained in the logbook. An exhaustive list of mandatory OPD procedures observed and performed should be maintained. And orthoptics and low vision workups, there is a minimal number which you have to enter in the logbook. So that covers mostly our pediatric and strabismology fellowship clinical. Neuro-ophthalmology has a separate program in our institute, and you have clinics again 9 months with 3 months of independent postings. And all allied peripheral postings like oculoplasty, pediatric ophthalmology, glaucoma, medical retina, neurology, neurosurgery, radiology, emergency management, and adult cataract surgery exposure is given in neuro-ophthalmology fellowships. And goals again are similar. Case presentations are routinely done. Interpretation of fields, imaging is supposed to be part of the training. And basic of neurooptometry rehabilitation is included. And logbook maintenance goes hand in hand. So the goals are finally to impart necessary skills and knowledge specific to neuro-ophthalmology, intensive training in diagnosing and treating neuro-ophthalmological disorders, to participate in clinical research, and comprehensive ophthalmology and emergency care is done, and cataract surgery training is also a part of a neuro-ophthalmology fellowship. And attending conference to present original work is also encouraged as part of a fellowship. So thank you. So an ideal fellowship of pediatric ophthalmology and neuro-ophthalmology is supposed to have these kind of goals.
Thank you, Dr. Kavita. Excellent presentation, really covering everything that is important. Dr. Ramesh, how much, as Dr. Kavita mentioned, the importance of having other specialties like neurology, pediatrics, medicine interact with your fellows? So how is it possible, or how would you kind of incorporate them when you are actually treating them in a more of a ophthalmology setup for the specialty exposure to other areas?
Yeah, I think most of the pediatric ophthalmology has other specialty, as you said. Neurology and genetics becomes a very important thing. So what we do at our institute is once in 15 days, we have a co-grand round with the neurology group. As in Western countries, they have a posting with them. Specifically, that becomes a little bit difficult. We have a co-grand rounds where we call radiologists, neurologists, neurosurgeons, pediatric neurologists, all of them we call, and we tend to present cases to them. So that way they can invite. Even with the genetic, we have once a month we call it as clinico-genetic correlation. So this is what we try to do, so that some aspect of it is they get removed.
I have a question to the expert. Is there a particular number and time frame over which we enter postgraduate, the fellows study? These many steps we hear, and over 3 months they will start doing it. Like cataract is a structured training. Is there something structured?
Yeah, the period. I will tell my thing and then I'll give it to her. Pediatric cataract, again, we look at their adult cataract surgery skills before we give it to them. And then even on simulator, they can try this anterior capsulorhexis. And we specifically ask all the resident and fellows to do adult cataract surgery doing a capsulorhexis forceps rather than doing it on cystitol. That's a stepping stone to the pediatric cataract. With regards to strabismus surgery, we have this, there are a lot of models available. That models can be tried in the initial stage to get your hands ready. Keeping it horizontal, holding the instrument, memorizing the steps, that gets okay. And once they graduate, we go into board side to train them on inferior rectus muscle, all that, to get a better feel. But what is the number? I would say around 20. With the short clips, they send it to the faculty, so that when they go back home, they will review these videos and give feedback. That's what we gradually do. I would ask Sujata to comment.
So there is no specific numbers, but we give them short steps and see how each individual is kind of progressing. So we have had fellows where the entire fellowship has gone in learning only rexus in adults. See, unless you can have rexus in adults, you can't give them in children, especially as Ramesh mentioned with your forceps. So, but otherwise, I would feel that in strabismus, we first make them scrub up and assist consultants. Then we switch the microscope and we make them just to give the conjunctival incision and to try and get the scleral bed. Then we get them to hook. So each 3-4 3-4 steps like that, and in a matter of 3-4 months, they are able to hook and pass the suture. It is something like that for strabismus that we do. We don't have any specific numbers. It is the way the clinician or the fellow has performed will make him go to the next step. I mean, numbers don't apply. This is actually, and we have seen it is a kind of individual how the particular fellow is shaping up. So some of them would have done plenty of surgeries and gone, and some of them would have gotten 1 or 2 or 3. So if we can't set numbers like that, it depends on the clinical set of the individual. Yes.
I just want to talk about the training of retinopathy of prematurity ROP screening amongst pediatric ophthalmologists. Now, we know that in India, it's done by retina specialists, do the screening and the laser and the surgeries. But outside India, especially in US and UK, the pediatric ophthalmology person are the one who take care. Many times I get people, they come for short-term ROP training, a pediatric ophthalmologist, because they have not been exposed that much during the pediatric ophthalmology training. So is there a standard? We know now ROP limits are phenomenally increasing everywhere. So is there a place where we can teach them a good screening of ROP? Forget about the treatment, at least there's good screening of ROP.
So our fellowship, we have a 1-month retina posting where they are supposed to accompany the retina surgeon for an ROP screening, but they don't end up really having that much exposure, which is enough or sufficient to call themselves independently to be able to do it. But there are some centers where they offer ROP screenings, short-term fellowships like 1 month like that.
Yeah, even we have a long-term pediatric ophthalmology, but unfortunately, even our fellows are not doing that. So it's sort of neglected everywhere.
But how long do you think the training should be for a pediatric ophthalmologist who is not retina trained to actually be relatively confident of doing? Because we've had this discussion and I've gone back and I've also thought it over, can be incorporated in our pediatric ophthalmology service. But anyway, these fellows are for us, our senior residents, are so anyway overworked that they themselves are not very keen to pick up. So how long do you feel they need a pure retina exposure, because they're not going to do anything else other than ROP?
I mean, a long shot, the ideal thing would be 4 weeks, but even 2 weeks should be okay. Like you were talking about the minimum number of cataract surgeries or squints. You can have minimum number of 20 babies that you can screen. That's good enough. Independently.
But the negative effect of that, if I feel okay, I am doing 2 weeks training and I can grade an ROP, and what if I miss? I mean, you would be erring in that. Better to have the retina people.
This is what the fear factor is. If you go with that,
but it's a true fear. Because time is
think
all the babies are coming to you.
And as a pediatric ophthalmologist, it is mainly in your domain.
And actually, what we see, we do not see these that newborn infants do not, if they have a doubtful referral, they routinely directly go to the retina department. We only see them after the retina people refer them to us for the refraction and those things after the initial part. So we don't see them looking.
I think the question here is there are 2 things. One is pediatric ophthalmologist doing it, and the second thing is what are the programs available. I completely agree with the doctor that all the pediatric ophthalmologists should be able to do pediatric ROP screening. We looked at maybe 40 or 45 fellows. What we do is each hospital, whoever does screening, ROP is a different ballgame. They don't come to us, we have to go to them. It's ICU based screening. Most of the times in a program like us, if they are posted in a month, they will have 10 to 12 sessions of screening. Each screening session will have around 40 babies. So with this, along with the training of laser, they will be trained on definitely who needs intervention, who does not need intervention. Laser, again, as Sujata said, some are very proficient, some are not. The last part is surgery. When it comes, I don't think so. Pediatric ophthalmologists are trained to do that unless they have another 1 year fellowship in retina, because it's very extremely delicate. So with regards to the ROP screening, they should be able to do it, and that's what we should adopt. In terms of training, I think in India at least 3 to 4 programs are there. Again, it's a 1 month. We have a lot of, even in Nagapurasad, we have a lot of 1 month training under the leadership of Subhadra Jalani. It's pretty okay. You will not have a fear. You can ask them, there is a questionnaire before and after. They are 100% confident whether this child needs intervention or not. This is what I think we should go towards.
And one more thing, Narayan has experts regarding lasers. I would like to add that, I had done a pediatric fellowship and I was told to ROP and I did that, but adult lasers is what we should do for a month. If you're able to handle it, then you can go
Basic
into
thing is not about lasers at all. Pediatric ophthalmologists, like you said, they should be able to screen,
Yes,
they should be able to diagnose, they should be able to when the child has to come back or when the child to refer. That's the basic thing.
For that, there are trainings where you can, and then they give you a month or 2 months to be able to identify or pick up.
I think suggestion is all the programs should go towards that. That's the whole summary. Completely agree with that.
We have the next speaker, Dr. Rohit Saxena, to take over on the very important topic of surgical skills and enhancement schedule. Rohit is a professor of ophthalmology and heads the department of Paediatric Ophthalmology at RP Center, and has been a great friend and support as a member ARC North, and I truly miss him. That is if I continue. So on.
Thank you, Dr. Chitra. There's been some wonderful years here at ARC, and of course, we've been for so many years trying to see how we can get each and every subspecialty to enhance its level of training of the fellowship, so that overall we see a far better set of fellows, senior residents in our case, who go out and are able to kind of push our specialty beyond the boundaries that we've seen it limited to at the moment. So I'll be talking about skill set enhancement, and some of it was discussed in the questions that we had. So more of a run through so that we get some diverse ideas from various institutions, and we can collate these ideas together to try and have these institutions get information from other places and get better. So essentially, advances in surgical skill training would be helping in transfer of these skills from one generation of the surgeons to the next. Particularly important in strabismology, where I would say, fortunately or otherwise, we do not have so much access to topographers and laser machines that do a lot of work for us. So we still are down to doing all these things with our own pair of hands, and therefore, to actually magnify the impact of what we are doing and all the training that we have, we need to transfer these skills on to the next generation, so that the good work that we have achieved goes on forwards and becomes even more. So the basic challenge again becomes, because we don't have too many tools to transfer or train them on, and they are again more white matter work. So the more that they get to do, the better they'll be, and the risk is that the more they do, the more complications we have to manage. So this is that double-edged sword we have to work and try to establish a surgical curriculum that balances these two and standardize the acquisition and the evaluation of the surgical skills. So just as a start, for any surgeon, you need to be very important about basic life support and CPR, strabismology, because we do use a lot of blocks as compared to cataract, which has actually moved a lot, adult cataract, which has actually moved a lot to topical, and of course pediatric cataract, where we have the support of the anesthetist. So when we are operating under block, we know that the risk, in fact I feel for cataract surgery, the riskiest part of the patient is the time when we are giving the block. I think the maximum complications now are probably in the block time. So same for strabismus. It's very important that our residents should be trained not only in giving the block appropriately. Sometimes we can get good akinesia, but we do not get good anesthesia, and the patient is jumping and crying all throughout while you're just keeping on infiltrating anesthesia again and again and again. And those are times when we are struggling. So it's very important for them to be able to understand how to manage these situations, and of course maintenance of the sterility inside the operating room and all the techniques that all residents and everybody who is in the OR should know about. From ophthalmology and strabismology, it's important to know about the relevant anatomy to be able to understand the various principles of the surgical procedure, the tissue handling that we're doing. So, residents, especially residents who rotate to us from the retina side, who have good experience of assisting buckling, are kind of uncomfortable with our, gentle handling of our tissue, and of course, nothing against fellow retina surgeons, some who may be sitting here. But I'm just saying that obviously their purpose is different and our purpose and approach is different. So it's important for them to get oriented with the way we find tissue handling to be there. And again, like I said, management of ocular emergencies that can come up. So these are very, very important things of skilling of the resident and the fellow that are essential before we start them. So before the operating room entry, we operate even strabismus now under the microscope. So it helps. You don't need separate tables for them. We don't need separate, experience for them to adjust to the loops or anything. So they learn to do strabismus surgery along with their learning of the cataract surgery. So them to be able to understand and handle the operating microscope effectively for residents, because we train a lot of our residents in this, and of course our senior residents, equivalent to fellows. So they need to be working together as a team so that they can enhance each other's skills and manage problems and complications that arise. We have a wet lab training facility which started off as a cataract where 15 hours of active wet lab time was necessary, and we were providing them a proper certification. Of course, that is for cataract surgery before they are allowed to handle any patient. We've moved, and I'll show you how to incorporate strabismus also into this wet lab. So we have this National Surgical Skill Development Center at the RPC where we give them hands-on training. There is the both side that we arrange for them. The surgery simulator is there, and of course with advanced training modules effectively for cataract. Surgical videos. So there are a period of discussion of surgical videos. We have all residents and fellows record their surgeries, and randomly or once a week each is selected to bring out one of his videos, and at the end of the week on a Saturday we have these presented and discussed to the entire group, so that again it's not something that is judgmental there. It's not that why and what about that person, but it is just to understand and let everybody gain from the experience of problems and complications and challenges that each and every person actually faced, and therefore that recording can help in that general discussion. And of course a wet lab logbook where each and every person's surgery is mentioned. So this is our wet lab where of course this was for cataract, and we kind of modified this to start talking about extraocular muscle surgery on the both sides. This of course got precipitated by COVID, the very, very few good things that came out of this. So the entire training of our residents for strabismus was shifted to the both side basis because there were hardly any surgeries that were being done. So we used to get the entire globe of the board with the muscles attached, and we would inspect these globes to identify that are all the muscles intact or not, and only those globes were selected. And then we positioned these globes. They were tied at the free end at the origin, which was the origin, at the base of the simulator eye, so that you could produce that little sense of tension on the muscle. So when you pass your hook and you're passing your sutures, you get that feeling of true passage of the suture. Again, the globe, as has been mentioned, the goat's eye is a little soft. So when you're passing your sutures through the sclera, you don't get the feel. So we would infuse or push in a little bit of viscoelastic in the globe to increase the turgor pressure, so that they get the real feel of the depth of the sclera when they are passing the suture through the sclera. That is again very important because the biggest risk is the perforation. So we have these residents or fellows go through both recession procedures. We went onwards in COVID to actually work towards giving them a simulation of the complex strabismus procedures for fellows and senior residents, as we call them. So everything from inferior oblique muscle surgery, we would ask them to measure and place the inferior oblique sutures depending upon what surgery. So whether it's any different kind anteronasal transposition also, they would at least get an idea of how to move the muscle and how to pass the sutures in relationship to the various muscles that are there. Of course, it's not a real field because really there's no conjunctiva, but it gives them an idea of how to measure on the sclera how to pass the sutures. So again, all these kind of, the superior oblique is also present there on the globe. So it was a very unique experience when we started doing PTSOs for them. So that was very interesting. All kinds of superior oblique procedures, including loop tenotomies, were taught to them on the both sides. So it was all a very interesting procedure. Again, pardon, how to measure, how to get these values. So all these were very hands-on, and an hour of training with them really helped get them get better and better with this. This is an alternative that has been published. Dr. Saurabh Jain has come out with this low-cost business model, which is essentially a golf ball, and using that. But I thought that was more according to them low cost, but with the non-veg being eaten in northern India, at least both sides would be relatively cheap for us. And in the operating room, the other important thing is to have closed circuit LED screens where the surgery can be displayed, recordings to all residents when they perform their surgeries have to be recorded. There are with observer arms, of course, they do not turn 180 degrees completely as they used to earlier, so that is a little bit of a challenge. And as I said, all have to record with the trainer. So this is just showing you how the fellow is operating with an assistant on the side. There is the screen that is there, and that can be instructed to somebody is observing the surgery that is going on. So this is one standard procedure where initially the fellows who are starting off surgery would be in this system here. So before that, discuss the instrument. So the nurse, the surgeon, all should know the sequence of handling and passage of the use of instruments. So first, the non-tooth hook, the tooth hook, the lens hook, and whatever is your surgical procedure. Again, once they see that, they know what to expect as an assistant and as a surgeon. So again, you have the assistant sitting on the side. They can observe almost to the finer detail exactly what you're doing, how you are passing the sutures. Again, while if I'm operating, I will be discussing the surgery simultaneously, so the assistant can understand what I'm doing along with the display simultaneously. So these are all our OR positions where we use both the teaching and demonstrating methods. All these are the discussions can go on simultaneously. These are very key, which we found beneficial. Of course, we have the 3D heads-up display system. We try to use it for strabismus. It is interesting. It does increase the surgical time a wee bit. Good for photographs and good for recording your video, but of course, it does not really add too much. The other thing is, of course, level-based training. You need to have your the kind of surgery that you're training them for intermediate, for beginners, intermediate, and advanced surgeons, and the kind of procedures they do. So your complex superior oblique surgeries, transpositions, all those are, of course, kind of kept for the advanced surgeons, the fellows. The senior should be with them all the time, so that any complication or problem can be actually checked at the same time. As I mentioned, we have them record and we have them discuss subsequently along with the surgical log. There are a lot of competency-based milestones that are there, not so greatly defined from strabismus point of view, but it's an ongoing process. I guess we should have more and more ways in which we will assess them and get better logbooks so that we can finally certify them to the level of competency they have. And finally, of course, discussion meetings, and the best meeting that can ever happen is like the AIOS. So again, advances, of course, like I said, simulation surgeries. Hopefully, they will advance to strabismus also. There is a whole lot of surgeries that they talk about, neurodevelopments in artificial eye, and of course, 3D printed eyes that can be used. So we look forward in the future to get these kind of options available for training our strabismus patients, surgeons. So thank you very much for the opportunity.
Thank you very much, sir. There are a few questions for the panel. There were some cadaveric courses for strabismus surgery that came up randomly on the. So and secondly, when we get the board size for cataract surgery, we usually have all the muscles cut. So we give some specific instruction.
Yes, so for the both side, yes, absolutely. We pay them only when they give us the both side of the muscles. So now, of course, initially the person used to go collect the both sides, used to collect it after cutting the muscles, but now he's been trained that when we goes with the enucleation scoop and everything, and he cuts them at the base. He's a good enucleator. So maybe for the eye bag people, if they want, but now they go to whole eye extractions. But, about you had asked about cadaveric surgical versus the is there?
So we move on to the next post, next topic. Academic, should be talking to us on academic involvement going forward.
Though we all know that when it comes to post-graduation and academic surgery, it's what most of them want. There is something beyond surgery, and that's what I'm going to be talking about, academic involvement going forward. So let me just take you through my journey. I did my post-graduation from KAM Hospital. And when it came to scale, I'm talking about in 2000, at that time I was doing topical phaco's. So it's something like this, you get a lot of surgeries in Mumbai. And incidentally, I went to attend a contact lens course in Eye Institute. And I got so fascinated by that, so I decided, yes, I am going to do my fellowship there because I had done surgery. Surgery was not an option for me. I wanted to know something beyond it. And that was my exposure when I thought that I have to go beyond it. And that's when I went ahead and did a fellowship in LV Prasad, and when I got exposed to academic. So when I was in KEM, we used to do a lot of surgeries, a lot of patients, but we never thought beyond surgery. That's all we was. And I'm going to tell you what all is needed by academics. So that includes knowledge, presentations, publications, training, and communication. This is what I will take you through. So let me go through knowledge. Now, what we have to understand that we don't know. I mean, you don't know what you don't know until you know, and that's the primary goal of any fellowship. Till you're working in a place, you really don't know what's happening. Unless you get an exposure elsewhere, it doesn't work. And that's what you should do. When you get a golden opportunity to do any fellowship, use and study as much as you want. You have to read books, journals. Now we have the option of recorded webinars also. So there's plenty of material and do it. Because once you pass out, from there you're never going to go and pick a book again. And remember, look at evidence-based medicine. It's just not about related to generally what people are just saying or doing. It's important. And it's only then that what your mind knows you will be able to see. And that is the important part of fellowship. Also, when you're with your teacher, watch your teacher examine, counsel, teach. Every bit you should know. Try to have the cases at the end of the day where you can sit and discuss, especially the complicated ones. You should exactly imitate your teacher and learn what to do. But interestingly, you should also be knowing what not to do in certain situations. Ideally, what I'm trying to say, before being a great pediatric ophthalmologist, try to be a great human being. So try to be teaching all your children, the patient, whatever you see, as an entire human being and not just the eyes. The other important aspect that can have and can be a part of the fellowship is a mentor-mentee program. It helps to improvise on your ability and capability and helps you sail through very important. So try to have this program incorporated in your system, or they may be many fellowships already have that. So you are evaluated by your mentor. But what interestingly can also be done is the mentee also evaluates the teacher, and if that happens, then both of them grow equally. That's important. Then also you have a lot of these social media where you can have discussion groups, their opinions in learning. So be a part of them. Stay in touch with the latest news, treatment meetings. So you're constantly learning at that. Like for example, I'm part of all these various groups and they keep on happening. So what a lot of cases where sometime or the other you will be going through, you have a direct access to, you learn, you see others discussing cases and you learn simultaneously with that. And then you should try to look at your niche areas before you decide to start your own. Like for example, as we discussed, you can primarily do something like ROP, you can do pediatric cataract, in addition to what you want to do, your strabismus. Now there's a lot of scope of pediatric neuro ophthalmology and CVI. There is also myopia, which is on the new kid on the block, and pediatric genetics. So there's so many options to pediatric. It's not like it's a huge thing. So you can choose something which you want to further pursue what you want to do. Presentation. This is something also that you can work on. Primarily start with case discussion, difficult or different cases, the method of diagnosis, management options, surgery, etc. You can present. For that, you need to have very good documentation, and therefore you can start with a case report. Like for example, a 6-year-old child with chronic kidney disease came, and all interestingly was to just look at the fundus, and you can see the papillary syndrome. So this is a small thing that you picked up, but you can use it present in a small areas where you can show it up. So that can be other things are presenting in journal clubs. You can have didactic lectures, which are like big ones or interactive ones. Newer technology to introduce. Do slit lamp photography with your phones. 9-days photograph app, which we are all friendly about. In whichever phone you have, you can use that. That can help in your documentation. Then you also have to then focus on various studies, like maintain Excel sheets of the squint cataract cases, about the morphology surgery. Once you start maintaining things, you'll be able to pick out so many things that you can use as presentation and also part of publication. Have your research projects in the interest on the topic that you like. Focus should be good scientific content, and beautify the presentation, which will add value to when you do presentation, like animations, transitions, whatever you want. So you enjoy doing them, and also people like watching them. So that can add to it. So then among your counterparts, you can stand apart. So it's basically to make your things much better by doing this. Then as a part of fellowship program in the institute, you do it regularly. This can be your classes and meetings, like we have it in our institute. You can be member of various societies, like the Bangalore for me, then the Karnataka state, for your individual local city and your state conferences that you can do. And also primarily because I'm from Mumbai, these are the other places where I can present. And then importantly, we cannot forget our national AIOS, where you get a chance to present. Then your specialty societies which are there, and international societies are there. So there are a lot of places where you start taking small and start projecting, so that people also learn in addition to learning your skills and what you have learned. And this is an opportunity to make your work present in the form of oral paper, posters, physically, your poster podium, etc., and even presenting a video. And don't forget to give exit exams which are there, like we have the Rajiv Gandhi University exam, but now we have the FICO that is there, that makes your talent also better, and you try to be able to get an actual degree to whatever you have done in your fellowship. Coming to publication, yes, that is also an important thing that you can learn as a part of it. You can have simple case reports or case series, observational and interventional series, which could be retrospective, cross-sectional, but plan to have prospective studies, because wherever you do in fellowship, you have a scope for doing it, and try to aim for RCTs before you leave. And try to review articles with your mentor. You would have a lot of places where they review the articles. You try to be a part, so you learn the reviewing process, and then you can help them do that as well. The other aspect is, yes, publication is there. Your local and state society journals and renowned journal like DOS, which has been there for long. A lot of people read it, so try to put something there. And our own IGO, which is now scaling very huge heights. And there are multiple options, like you can put it as a case report, as photo essays, as OMO, which are there. These are small things. So whatever you are able to do in your practice or in your fellowship, you can even definitely put in, review with your teachers, write for, and with your mentors, so that you learn how to write. That is very, very important. This is, as I said, it's important to do best during your fellowship time. Then the other is try, obviously, for high impact journals, finally, where it can help in, and your specialty journals as well. So here we're talking about the Paediatric ophthalmology journals. So try to put in before you leave with it. And have your targets when you're planning to do it. So certain fellowships anyway have the targets, but if not, you can have that. At least one case report should be there before you leave, or retrospective studies are done. And once you're out, you can continue to do the same thing, right? And one research project. So try to have targets so that you can work on your academic part as well, help yourself to grow as well. Then important training, that is in addition to not your training. Training others is what can also help you to grow. And that's the aspect which I want to tell. Teach your junior fellows, the postgraduates, take lectures related to it in terms of normal evening classes or workshops, or in the clinics in after 15 hours, and that will help you grow further. You will know where your deficiency is and you can work on them, and that will also work. Assist surgeries, one learns better when you are assisting than you are actually doing it, because you're not the operating surgeon, so you don't have the fear. So can handle complications, take proper decisions better when you are trying to assist as well. And then obviously your mentor is happy that you're able to do that. And then importantly, the last part is communication. This is also very important. What we have to look, because how we should be able to talk to our patients is important. And what we need to understand, it's a child. So it's hardly talking to the patient, that is a child, but to the parents, and how importantly to handle them is there. Explain to the parents the problem and also the treatment, and that helps build a very good rapport. Learn to handle unhappy patients and see how your teacher, your mentor is handling the same. Always ask the question why, so that you know how to treat it. Like for example, this 62-year-old female who came with gradual constriction of vision in both eyes. You can see there is completely constricted fields, both eyes pseudophakia with normal retina. But it's importantly why this happened. And a proper history showed that this was cancer associated retinopathy. So yes, ask questions. Sometimes they say there's no treatable condition, there's nothing you can do, but more than that, why it happened so that you are able to improve your knowledge as well. Then the other aspect, right, counseling and treatment goals, you have to talk, especially in conditions like pediatric orphan and strabismus, we have to be correct in what we say. Like for example, this patient with the right third nerve palsy, as you can see, only the moving lateral rectus muscle. So you have to counsel well that it may require stage surgery, and eventually we may be able to only get the eyes to the center, not anything more than that. Like this is what we got, good outcome, but there will be no motility. So really importantly, tell them what is the final goal, that they do not have too many high expectations, how we can achieve it, and what are the limitations, and maybe requiring stage surgery. But always remember never to give up on treatment. Certain conditions we may not be able to do, like retinal dystrophies, but remember there is always rehabilitation available, especially in a child. Vision stimulation and visual rehab should be done because the child has the entire life to go. That is to be importantly decided. So in a pediatric ophthalmology, look at the child as a whole. One has to rule out other systemic issues and syndromes which are commonly there in children. So exactly, you may need to have a very good coordination with other specialties like pediatricians, the clinical geneticists, neurology. That's a must. You have an entire teamwork who looks at the child completely and not just looks about the eye. And that is the most important part. So I want to end up by saying that some people may always throw stones in your path. It depends on what you want to do it. Build a wall or a bridge. Remember, you're the architect of your life. Be thankful of what you get and make the most out of it. Enjoy your fellowship journey and have a wonderful life. Thank you very much.
Thank you, Jyoti. That was wonderfully informative as well as inspirational. Thank you very much. Any comments from Ramesh? We'll be ending the session, so any comments on how, any key comments or anything, how we could improve the structure of our pediatric ophthalmology fellowship programs for both pediatric ophthalmology and neuro? What as a team, as a group, or
I think to summarize, we, from the clinical point of view, we can incorporate other specialty trainings. Surgically, we can incorporate simulators, and academically, Jyoti has beautifully mentioned, improve communication, improve publication studies. So I think this is all summarized from the entire session.
Everything is summarized, right? I just had one comment. We must have some kind of periodic assessment and feedback because that will get the best out of the fellows. So, be it monthly or bi-monthly or once in a quarter, some kind of feedback system is important because in our experience we have seen some fellows are up to the mark, some of them are not. What we are trying to do is we are not comparing fellow A and B, but fellow A or B is making a progress, gradual progress is there or not. That I think feedback is very important. That's all I have. Thank you.
Kavita, any comments? So I think what she had to say she already given enough. So I think thank you very much. We close the pediatric ophthalmology and neuro ophthalmology session for fellowship training.